Well, I think you can all see that the groups have been very hard at work over the last year and have made amazing progress. We have about 15 minutes for questions, so I invite you to the microphones. And I think we have a number of questions already. Yes, please. And please direct your question to one of the groups or all of the groups, depending on what the nature of the question. And try and keep the questions as questions and relatively short.
Okay. Hi there. I'm Nancy Spangler. I'm here with Greenleaf Integrative. I had the pleasure of being with Cliff Knight and his organization week before last. The American Academy of Family Physicians had the first ever well-being conference, and I was thrilled to hear the deep concern for patient well-being. So I would like to acknowledge you for really focusing on that and putting that at the center. If that's at the center, how might we move toward measuring that more? How might we look less at quality measures for health care and quality measures for patient well-being?
Bob, Steve, you want to take that one up?
I mean, I think you raise a very good question there. I mean, too often our outcomes measures tend to be proxies for what we think should make our patients happy and satisfied. And I think what we're seeing is both at an NIH level, where we have the PROMIS scales in various domains, but actually throughout outcomes research, the idea is that we want to look at the quality of life of our patients as the primary outcome measure. And I think one very important aspect of what this group could do would be to link the physician quality of life to patient quality of life. I suspect there's a pretty strong positive correlation there.
Art?
So I think as we designed that conceptual model, one of the things that we really dwelled on a lot was what went to the center. The patient, as you see, is in the center. And I think what we heard about how this is going to be dynamic, we're probably going to have to change some of those factors over time as we listen and hear what's going on. And I think what you saw with the Knowledge Hub of how we're going to ask, did it help you? Were these the right things to be checking? So I don't think we have those answers yet, but I think we're a group that's committed to try and find out what they are and change things so it works.
Right, Dyer? Tell it.
Good morning. My name is Paul Bush. I'm president of the ASHP, one of the sponsoring organizations, and want to thank you very much for allowing us to participate. My question or my comment really relates to what I think is an excellent tool, the conceptual model. I've used that many times with my colleagues at Duke or whether they're at ASHP. And I don't know, I suspect you were going to prepare a slide set. But if you could prepare a slide set to go with that, I could see that as a 30 to 40 minute discussion with a lot of individuals. And I think we do have so much learning to do before we can really get to solutions, and that's a great tool for the learning. Do you have ideas about maybe a slide set?
Thank you very much for your comment. We do, because we want to make it as helpful as possible. I think what you're talking about is putting those things out and really letting a leadership team or a community look at what is most operative here, what are the things to talk about, where do we prioritize among this, will be absolutely key to making this work for people.
Well, thank you very much.
Cliff, did you want to add anything? I think that would appear on the Knowledge Hub as soon as we can get it developed.
Hi, I'm John Ripp from CHARM and also Chief Wellness Officer at Icahn School of Medicine, Mount Sinai. My question is for Art and Lois, again, about the conceptual model. And first of all, thank you for taking that on. It's a huge effort, as was evidenced. So really a question, a comment. First, I think I love that you have placed greater emphasis on the system over the individual. I think a 4-to-3 ratio, however, is probably not the right balance, and I think the evidence probably shows that. I tend to think of it as 4-to-1, the kind of 80-20 rule. but that's just what strikes me. The question I have, so I'm sure you're tackling with the complexity of the model. Many of you may be familiar with the Stanford model that just has 3 wedges of a pie chart. It's very simple, and I think it resonates with a lot of people. So I'm wondering if you sort of alluded to, I think maybe it was Neil alluded to it in terms of the website and how you are perhaps planning on taking something so complex and making it a little more user-friendly so that it resonates more with people.
Thank you for asking. Yes, we began with 3, but then I think it became more and more complicated and complex because understanding different dimensions might be key, and having this as an entry point. Linking it to the Knowledge Hub, and maybe Neil will want to say something, we anticipate that there will be greater harmony in language between the conceptual model and the Knowledge Hub over time, that when organizations or individuals find things that they particularly want to go to, it will be tech-enabled, so it will take you to the appropriate place within the Knowledge Hub. And then a variety of things ranging from was this helpful to where are people looking will undoubtedly lead to not only the Knowledge Hub changing over time, but very definitely the conceptual model changing over time to become more and more useful.
Neil?
So in terms of the future integration of the conceptual model and the Knowledge Hub, you can imagine that you could have the conceptual model viewed sort of at the 50,000 point view, external, internal, patient, and then zoom down. And the beauty of this is that although the Stanford model is nice conceptually and we use it, it doesn't give you concrete suggestions for what to do in your institution. And as the classic Shanafelt Noseworthy article states, what's important is what's important at your institution. All burnout is local, just like all politics is local. So this would give you the opportunity to zoom in after asking the right questions at your institution. What factors are operative at your place, and then using the conceptual model, bridging into the Knowledge Hub to get to those solutions.
So I think that you're just seeing the beginning of what the quality, I think, is going to come of this. The best thing that happened was that we're going to have 2 additional years to really work with this and really develop it. And although there's stuff not ready for prime time, we got a lot we're thinking about that's going to end up in this thing for you all to use over the next few years.
Dorothy Erlanger. I actually work much more on the practical solutions delivery side. And first of all, you have made remarkable progress with that Knowledge Hub in a very short period of time. My question really could go to almost anybody on the panel, but it's probably mostly for Neil or Cliff. What are you doing, and how can you measure our clinicians actually engaging with this? How are you driving the connect to those solutions so that people actually come to that very nicely simplified resource?
Yeah, thanks. We've thought about that, and our working group will meet regularly, and so we're going to be following the metrics. How many unique visitors have been to the Knowledge Hub? What resources they are pulling off of that. We're really going to be following that to try and get a sense of what are people most gravitating towards and using, as well as Neil pointed out, we've tried to make that really prominent, the feedback, and we really look for people to go to the Knowledge Hub, look for what they're seeking, and if they can't find it, especially if they can't find it, let us know what they're looking for that's not there so that we can fill those gaps. And that's really how we're approaching it, at least initially, and then we'll see what we learn from that.
There's another project going on from one of the other groups, which is a survey of which of the Action Collaborative's products are most helpful and what's missing. And one of the other groups might want to comment on that.
Yeah, that's what I was going to say. I mean, one of the things we're going to send out soon is a survey to try to assess what kind of impact this collaborative is having. And that will include things like, what are organizations doing to improve well-being, to address burnout? And that should be ready to go out soon.
Yeah. I would just add that one of our other goals here is to use the organizations that are co-sponsoring this initiative to link to the Knowledge Hub, to extend it out down into the fabric of all of our organizations, both member organizations as well as individual institutions, to try and maximize the benefit of it.
Right.
Yes, please.
Hi, I'm Christine Bechtel. I'm a consumer advocate and the co-founder of X4 Health. We are just kicking off a project to look at reinventing the doctor-patient relationship. And we're testing the idea, so my question is about the conceptual model. But we're testing the idea that maybe it shouldn't be just patient well-being at the center of the conceptual model. And as a consumer, that's a very weird thing for me to say. But the idea is that we might be able to bring clinicians together with patients in a room, a small group, and really talk about what is it like to work in the system, because we don't talk about that with patients. Patients don't know it. And talk about what is it like for patients to receive care in the system, because sometimes I feel like my clinicians don't get it. And whether we can develop a real empathy for each other and then create some advocacy that's grounded in a different place than traditional advocacy, which is authenticity, empathy, and vulnerability. So I have two questions. One is whether the conceptual model is open to change at that sort of core level, that real nucleus in the wheel, not just the factors on both sides.
I would point out that there were few things more talked about or debated than what you have talked about. Also, that part of that core is the patient-clinician relationship.
Yep.
And there is nothing immutable about this model. The point is to develop it and have it be an ongoing, so it is most useful.
Great.
I think you bring up a very good point about the two-way exchange of information. This is obviously a very important topic, burnout among healthcare professionals. But I have a lot of friends outside of the medical field, and I talk to them, and, you know, when I bring up this idea of burnout, the initial reaction is often, okay, but, you know, I'm working 2 jobs, I live paycheck to paycheck, I'm not sure what's going to happen to my kids, and, you know, a lot of people, a lot of our patients feel really burned out. And I think we have to avoid the feeling sorry for ourselves approach to this and really have a two-way exchange about things that affect everybody's life.
So that's actually my second question, and that is so important. I'm really grateful that you said that, which is for the messaging group. So has there been messaging work done about how patients think about burnout and well-being? I'm worried, obviously, because I think if we walk into this the wrong way, it'll set us back and we will fail to leverage what I think is a hugely powerful partner, which is patients and families.
I completely agree, and we are quite aware of the fact that different audiences need different messaging. There's the move among some people to say, well, make it a crisis because then you'll get action. On the other hand, you scare patients. So, you know, you have to, it's a yin-yang. You have to both emphasize both positive and negative aspects. What we've tried to frame it as is a patient safety issue, a patient quality issue, the fact that we understand this and that we, with patients, will team together to make this better so that everyone will do better, the clinicians and the patients. And we are still actively researching even better ways to message to patients, and we would certainly invite feedback from anyone in the audience or who's listening on the web about how to do this.
Lois?
I just want to underscore something that you've alluded to, which is burnout is an issue in society right now. And you can look at teachers, you can look at university faculty, you can look at factory workers, and you will identify that this is a huge issue. This is a public health issue right now.
Okay. Unfortunately, our time has expired, and there is one thing that is true. You must listen to Charlie. So thank you all very much, and thank you, members of the leadership here, for all your work.